This is Brian Wood from the University of Washington. In this National HIV Curriculum mini lecture, I'm going to discuss the combination tablet Doravirine-Islatravir, which was recently approved by the FDA as a treatment option for HIV-1 infection in certain clinical situations. Now, this is a two-drug combination tablet. Doravirine is an NRTI. Islatravir is included in the NRTI class, but it has a unique mechanism of action in that it blocks translocation. So it is also known as a translocation inhibitor. I will come back to that mechanism and talk more about what it means and why it is unique. Now, based on some trials, which I will also review, the FDA approved Doravirine-Islatravir as a complete regimen for HIV-1 treatment, and it is indicated to replace a current regimen for adults who have already achieved a suppressed viral load on other regimens. The other parameters of the indication are that this should only be used for HIV treatment for individuals with no history of virologic failure and no known or suspected resistance to doravirine. There is only one dosage available, doravirine 100 milligrams combined with islatravir 0.25 milligrams, and it is taken as one tablet by mouth each day with or without food. There are some key drug-drug interactions to consider. One that I want to highlight is an interaction between islatravir and 3-TC or FTC. This interaction is noted in the package insert and is significant because if doravirine-islatravir is combined with 3-TC or FTC, it decreases the levels of the active metabolite of islatravir, so may compromise islatravir activity. So this is really important to note if you are ever considering doravirine-islatravir along with other antiretroviral therapy options. Now, I will give the caveat that there are not a lot of data for combining doravirine-islatravir with other ART in the first place. So I would only consider that if there are very few other options for effective antiretroviral therapy for an individual, but it is something that may come up, and it is something we will see more research about in the future. So I do think it is an important point to know. Doravirine-islatravir is also contraindicated with strong CYP3A enzyme inducers and should not be co-administered with moderate CYP3A inducers either. Now, the combination may cause some general symptoms and GI side effects like diarrhea, dizziness, fatigue, abdominal distension, and headache. The doravirine component has been a cause of very rare severe skin reactions like SJS, TEN, and others, but again, in clinical practice, that is rare. There are insufficient data for use of doravirine-islatravir in pregnancy. No dose adjustment is indicated if a person has mild to moderate hepatic impairment, and it has not yet been studied with severe hepatic impairment. Now, another important note is that doravirine-islatravir can be prescribed if a person has an estimated GFR of 30 or above. So it can be used in the setting of mild to moderate renal insufficiency, which is an advantage. It is not recommended if a person has an estimated GFR below 30, and it has not yet been studied in dialysis. Now, I'm going to spend a minute on the mechanism of islatravir because it is unique. It is different than all of our traditional NRTIs. It is the first antiretroviral that has this specific mechanism of action. Again, it is included in the NRTI class, but specifically is a translocation inhibitor. So let me talk a little bit about what that means before I get to the chemical structure and the unique components. And there are some figures and animations in the other parts of the National HIV curriculum that can help you to better understand the activity of reverse transcriptase. But let me just review for a moment. So remember that the reverse transcriptase is what is building viral DNA by reading viral RNA as a template. So what the enzyme does is it adds nucleosides or nucleotides one at a time to a growing and elongating DNA strand. So one nucleoside or nucleotide is incorporated, and then the enzyme shifts forward one position and then adds the next nucleoside or nucleotide. So it's that shifting that is translocation, that shifting forward of the enzyme one position in order to add the next building block. That's the translocation process. And that is where islatravir has its unique mechanism of action. So traditional NRTIs lack this 3' hydroxyl group. So that is what is indicated here in green. So traditional NRTIs, so tenofovir, AZT, abacavir, others, lack this 3' hydroxyl group, and it's that group that is necessary for the next nucleoside, the next building block in the growing DNA chain to chemically bond together and keep the chain building. So the traditional NRTIs basically act as decoy nucleosides or nucleotides, get into the chain, but don't have this sort of necessary bonding element to keep building the chain. So that's the way traditional NRTIs work. Now, islatravir, as you can see here, is different. It has this 3' hydroxyl group, so it really does even more closely resemble natural nucleosides, and this helps it really efficiently incorporate into the building viral DNA chain. But then what's unique is it also has this 4' ethinyl or ethinyl group. This is indicated in the purple. And this is a really key, unique difference. So basically this 4' ethinyl or ethinyl group, I've heard it pronounced both ways, fits into this pocket in the reverse transcriptase active site. Notably, that active site contains M184, which we will come back to. But this can block translocation, block movement of the reverse transcriptase enzyme itself so that it can't move forward to the next position, thus making it impossible for the enzyme to add the next building block. So it's that movement of the enzyme that islatravir blocks. And then if the enzyme does move forward one position, that 4' ethinyl group has basically deformed the enzyme. So even if it moves forward one building block, it can't move forward after that. So there's an immediate chain termination effect and also this delayed chain termination effect. I was trying to think of an analogy. I've heard others describe this like an old school typewriter where the carriage that moves forward in order to print another letter on the piece of paper is like the reverse transcriptase, and islatravir blocks the carriage from moving forward. But I was trying to think of a more modern analogy, particularly because some may not remember those old school typewriters that well. And I was thinking about a 3D printer. So if you think about a 3D printer, there is a print head that continually moves forward along a template, and it lays down material. It lays down this element, and that material is like the nucleosides or nucleotides. And so the traditional NRTIs are like decoy element. It gets into that material that's building and doesn't have the bond to add more material to it, so it just stops. On the other hand, islatravir blocks the print head. the mechanism that's laying down the material blocks it from moving forward. So it is unique. It basically deforms that print head and makes it so that it cannot keep moving. And even if it does move a tiny bit, it then gets stuck and stopped. So hopefully that 3D printer analogy is useful to you. It helped me in terms of thinking about the difference between islatravir and traditional NRTIs. And then the last note here in blue, islatravir also has this 2-fluoro group. And the reason that's important is because it blocks metabolic degradation of the medication, and this is what helps it to have a very long half-life. Now, you may remember that for a period, the FDA placed a partial hold on development of islatravir, meaning there was concern about the drug, and after the original trials had started, they had to pause on enrollment and for a period could not enroll any new participants. And the reason was that those individuals in the trials receiving islatravir seemed to develop lymphopenia, and this included decreases in total lymphocyte count, CD4 T cell count, and also B cell count. And then what was discovered was that this lymphocyte toxicity was dose dependent. It also was found to be reversible, and it didn't lead to an increase in infections, but because of concern, what happened was the company that manufactures the drug resumed studies, but with a lower dose. And this was based on some trial data like what I'm showing you here that, again, found that this lymphocyte toxicity was dose dependent. In other words, whereas the original once-daily Doravirine-Islatravir trials used 0.75 milligrams of islatravir, trials were resumed using the same combination of medications, but with 0.25 milligrams of islatravir, which seemed to be safe. This is a summary of those trials. So you can see in the top section, the original phase 3 studies that used the higher dose of islatravir, the 0.75 milligrams in combination with doravirine. And then at the bottom, you can see the trials as they were basically repeated, but with the 0.25 milligrams of islatravir combined with doravirine. These first two, 051 and 052, I will show you in more detail. 053 is a study comparing doravirine-islatravir to bictegravir TAF-FTC for treatment-naive adults with HIV. And we have seen some results, but I want to be clear, the FDA indication for this medication is only as a switch option for individuals who have already achieved viral suppression. There is not an indication, at least currently, for treatment-naive individuals. And then you can see 054 is an open-label study using the lower dose of islatravir and enrolling participants who previously received the higher islatravir dose. Let me just show you a little bit about the switch studies that led to the FDA approval of doravirine-islatravir. So in this trial, 051, investigators enrolled adults with HIV-1 who had suppressed viral loads for at least 3 months while taking any stable 2-drug or 3-drug oral ART regimen. They could not have a history of treatment failure, and any known or suspected resistance to doravirine was also an exclusion. And then I noted here that active hepatitis B was excluded, but a positive anti-hepatitis B core antibody was allowed. So let me pause on that note for a second. So doravirine-islatravir obviously is a 2-drug antiretroviral therapy option, and it does not include TAF or TDF. Because it does not include TAF or TDF, it is not effective against active hepatitis B. Also, because it does not include TAF or TDF, there is concern, just like with other 2-drug options that avoid TDF and TAF, that if a person has previously been exposed to hepatitis B, they have a positive core antibody without a positive surface antigen, there may be a risk, albeit low, there may be a risk of hepatitis B reactivation. So there's been a lot talked about lately with this. It's a potential topic for a whole different lecture, but I just want to note here that a positive hepatitis B core antibody was allowed, and that's important because many of these individuals switched off of TAF or TDF. I will come back to that. So you can see here that participants were randomized in 2-to-1 fashion to either switch their baseline regimen to the 2-drug, 1-tablet daily Doravirine-Islatravir or continue their baseline pre-enrollment oral ART regimen. I'm not showing you full baseline characteristics, but I picked out some of the characteristics that I thought were worth mentioning. So you can see here, just under 30% in each arm had a positive Hep B core antibody. Very few had a CD4 count below 200. Most had been diagnosed with HIV quite a few years ago. And you can see here the baseline ART regimens, most of which were integrase inhibitor based. The most important finding of the trial is that Doravirine-Islatravir maintained virologic suppression at a non-inferior rate to continuing the baseline oral ART. In other words, Doravirine-Islatravir was as effective as continued baseline ART. There was no significant difference in CD4 count or lymphocyte trajectory when comparing the two arms of the trial, so that gives reassurance about the safety of this relatively lower dose of islatravir. And then returning to the hepatitis B concern, just to reiterate, for individuals with a positive hepatitis B core antibody, there is some concern that switching off TAF or TDF to a 2-drug regimen that does not have any anti-hepatitis B activity may increase the likelihood of hepatitis B reactivation. But again, data here are reassuring. Even though almost 30% of participants in the trial had a positive hepatitis B core antibody, only one individual in the Doravirine-Islatravir arm developed low levels of hepatitis B DNA, in other words, a detectable hepatitis B viral load. At screening, this one individual had a positive hepatitis B surface antibody, a positive core antibody, negative surface antigen, and no hepatitis B DNA detected. You can see here at week 12, 24, and 36, hepatitis B was detected first at 85 copies, then at 202 copies, and then on repeat, not detected at all, and that is without any change to ART. All hepatitis B surface antigen tests remained negative, and this individual did not receive hepatitis B treatment. So overall, I would say evidence of hepatitis B reactivation was very rare. One participant had some evidence, but the clinical significance is not yet clear. Now, another outcome of interest in this trial is comparing Doravirine-Islatravir to continued baseline oral ART in terms of what happened to weight trajectory over time. Now, there was some optimism that a switch to Doravirine-Islatravir may be beneficial for metabolic outcomes as compared to continuing other agents such as integrase inhibitors, TAF, and others. What I would say is this data, along with other data, suggests that the switch really did not have weight or metabolic benefit. Now, if you look at all participants on the far left, you can see that those who switched to Doravirine-Islatravir did tend to gain more weight. However, if you look in the middle, specifically at those participants who switched off of efavirenz or TDF, you can see that the overall difference in this outcome was driven by those participants who switched off of one of these two meds. And that's consistent with what we've seen in other research. Efavirenz and TDF seem to have a weight suppressive effect and it is switching off of efavirenz or off of TDF that tends to lead to relatively higher weight gain as compared to other options. In looking at this outcome, when participants who were not taking efavirenz or TDF at baseline were removed, there was no significant difference in weight trajectory comparing a switch to Doravirine-Islatravir to continued baseline ART. In 052, the other principal phase 3 switch study that led to the approval of Doravirine-Islatravir, the design overall was similar. The difference is that participants were all taking bictegravir-TAF-FTC or BIC-TAF-FTC at enrollment. So these were adults who had achieved virologic suppression on that combination, had no history of treatment failure or known resistance to doravirine, and again did not have active hepatitis B, but could have a positive hepatitis B core antibody. And participants were randomized to either switch to Doravirine-Islatravir or continue bictegravir-TAF-FTC. Here again, for a group of adults who had achieved virologic suppression on BIC-TAF-FTC, who did not have a history of treatment failure and did not have concern for drug resistance, a switch to Doravirine-Islatravir had equivalent efficacy as compared to continuing the BIC-TAF-FTC. Again, of those participants who had a positive hepatitis B core antibody at screening, evidence of Hep B reactivation was very rare. 2 participants developed detectable Hep B DNA levels during the study, but again, very low levels. One of those participants continued Doravirine-Islatravir and the other withdrew from the trial. I will just add that this is consistent with other study data as well that shows that these Hep B reactivations are rare. The Hep B DNA levels are often quite low, and I think the clinical significance is to be determined, but it is something to be aware of. Now, 2 new Hep B infections did occur, and that is also notable in the sense that if a person is taking Doravirine-Islatravir or really any 2-drug ART option or any ART option that does not have TAF or TDF, they are at risk for acquiring hepatitis B if they are not immune. So the other thing I'd like to emphasize here is the importance of hepatitis B serology screening and vaccination, and this data emphasizes that importance. I'll also add an aside that the OI guidelines were updated to add some language about switch of ART in the setting of a positive Hep B core antibody. So if this topic is relevant to your practice, please take a look at that as well. In this trial, similar to 051, there was no signal showing a metabolic benefit to switching to Doravirine-Islatravir. There was no significant difference in changes to lipids, weight, or insulin resistance, and you can see the mean weight change there at the bottom. Now, I'd like to turn to the topic of resistance and considerations with Doravirine-Islatravir. First, let's talk about NRTI resistance. Remember that doravirine retains activity in the setting of some common NRTI resistance mutations, for example, the ones I have listed there. I do want to remind you that there are other NRTI mutations that can compromise the activity of doravirine. So if you are reviewing a person's resistance profile and there are NRTI mutations, you should always do a review and double check about the predicted activity of doravirine. Now, a possible advantage of Doravirine-Islatravir that's been discussed is the 2 medications seem to have opposing resistance pathways, meaning that some mutations that can cause high-level doravirine resistance actually increase the potency of islatravir. In other words, there's a cost to the virus of developing and maintaining some NRTI mutations, and in theory, this could create synergy and help to avoid development of resistance, but I would say that piece is largely theoretical to date. I think one of the biggest outstanding clinical questions about islatravir is how much each of the specific NRTI mutations affects its activity and how specific combinations of common NRTI mutations may impact it as well. The Stanford database, which is a very powerful tool for assessing the impact of specific drug mutations, has added islatravir. And what I'm showing you here is an estimate of the impact of some common NRTI mutations. Some things are known. For example, the K65R mutation seems to increase viral susceptibility to islatravir. On the other hand, the M184V or M184I mutation seems to compromise its activity. Remember that the key binding of islatravir in this pocket of the reverse transcriptase enzyme is right at the site of the M184 residue. So alterations to that binding site certainly can affect its activity. The degree to which I think we need to understand better, but the important takeaway here is that some NRTI mutations may increase susceptibility to islatravir, while others, including the most common NRTI mutation, the M184V, may reduce its efficacy. Now, in general, in clinical practice, I would say it is unlikely that we will be prescribing Doravirine-Islatravir to individuals with significant NRTI resistance. However, if for various reasons that is an important consideration for one of your patients, this comes from a really excellent publication that I would encourage you to look at. This gives some considerations and potential guardrails around prescribing Doravirine-Islatravir in the setting of NRTI resistance. Again, I think we need to understand this better. I think we need formal guidelines around this, but in the meantime, this is some of the best guidance I have seen. So for adults with virologically suppressed HIV-1 infection with no NRTI or NNRTI resistance history, Doravirine-Islatravir should be an appropriate switch option. I think, again, with key clinical considerations being hepatitis B, co-infection, renal function, and drug-drug interactions. If an individual is known to have an M184V or I NRTI mutation, the clinical efficacy data are lacking. This group gives the guidance to consider alternative options pending further data, unless potential benefits clearly outweigh the uncertainty. I would say that in clinical practice, I am unlikely to recommend or prescribe Doravirine-Islatravir in the setting of an M184V mutation until we know more. If a person has an M184V and thymidine analog mutations, the impact on efficacy really is not yet established and should be avoided. And as I mentioned, the K65R mutation actually increases susceptibility to islatravir. So Doravirine-Islatravir may be an appropriate switch option due to that hypersusceptibility, though again, personally, I will hesitate to prescribe this option even in the setting of a K65R until we know more. So in conclusion, Doravirine-Islatravir is now an FDA-approved HIV treatment option. I should have noted this earlier. It is also the first approved two-drug ARV combination that does not include an integrase inhibitor. So that may be an important consideration for individuals who do not tolerate integrase inhibitors for whatever reason. The clinical data to date are primarily for switch after achieving viral suppression on other oral ART. The indication is for individuals without history of virologic failure and without known drug resistance. If the combination must be considered for someone with known resistance mutations, I think it's important to consider the specific NNRTI and NRTI resistance mutations. Again, I think it's also important to consider the significant drug-drug interaction with FTC and 3TC, and also consider hepatitis B status and renal function, as well as other drug-drug interactions. Now, the data I've shown you also support ongoing development of other islatravir treatment combinations, and I think this is really good to know. There is an oral islatravir lenacapavir once per week treatment option in development, and also a once per week combination of islatravir with a novel long-acting NRTI called Doravirine that is being studied. So we may see new approved combinations of islatravir in the future, including the potential for once per week options that include this drug.